This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard of Cardiology Specialists of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
Welcome to our podcast on the treatment of pulmonary hypertension, where vasodilator medicines don't work. So last time we had a great podcast on what is pulmonary hypertension. Basically, when the pressure is high in the arteries of the lung and on the right side of the heart. We've described 5 different groups of patients with pulmonary arterial hypertension, and we're basically focusing on the group 1, or patients with pulmonary arterial hypertension, including some patients with connective tissue disease and mostly idiopathic type. We discussed the presentation and the workup and how necessary it was to perform a right heart cardiac catheterization. And we mentioned also, while in the cath lab, how we can establish whether the patient has a vasodilator response. Obviously, understanding that's the minority of our patients. So what do we do in patients that do not respond to vasodilator therapy? This is what we are discussing today. But first, Barry, if you could maybe talk a little bit about what is our goal of therapy, of medical treatment in these patients?
Sure. Well, like in everything in medicine, when we set out on a course of treatment, it's good to have an idea of where we're headed, what our goals are, as you say. And there's different ways to look at that in treating type 1 pulmonary arterial hypertension. We have data that helps us to understand which guideposts or markers along the way seem to correlate in the longer term with better outcomes and better survival. So we really focus on those. And they fall into 2 categories. They fall first into the clinical category and then second into hemodynamics. On the clinical side, what we're looking for is an improvement in the patient's functional status. Last podcast, we spoke about the WHO functional classification, which is very similar to the New York Heart Association functional classification that many people are used to. We like to see an improvement of at least 1 functional class, or depending on where you're starting, we'd like to get you to class 1 or 2 if at all possible. We also look at a measurement called the 6-minute walk test, and we follow those serially as we care for patients. And we'd like to see that get above a certain threshold that predicts a good outcome. So those are 2 clinical measures that we'll track over time and use to judge or get a sense of how our therapy is progressing. In parallel to that, from a hemodynamic perspective, we know this is a disease fundamentally of abnormal pulmonary vascular resistance. So we like to keep track of those hemodynamic markers that we know are involved with prognosis, such as right atrial pressure and cardiac output, both of which reflect the health or the well-being of the right ventricle. And ultimately, that's the organ that takes the hit in this disease. So we like to follow those, perhaps a little less frequently than the clinical parameters, but still on a regular basis.
So it looks like basically we want to improve quality of life as well as survival by improving or maybe decreasing the deterioration or maybe improving the adaptation of the right ventricle to this disease where the pressures are very high in the lungs. That's good. Well, Jason, maybe if you could tell us a little bit about what are some of the general measures that you implement in your treatment of patients with pulmonary hypertension?
Some general treatment measures of pulmonary hypertension, what we call supportive therapy, is incredibly important. There's kind of 5 major ones. One is oral anticoagulants. So in certain cases, in select patients, we will use blood thinners, whether that's warfarin or some of the direct-acting oral anticoagulants like Pradaxa or Eliquis or Xarelto. So anticoagulation or systemic anticoagulation may be something that your doctor recommends for your particular case. Second would be diuretics. So a lot of times when patients have right heart failure, they'll develop volume overload or volume retention. This can be treated with diuretics. There's a whole host of different diuretics that are used, but the idea is to get fluid off of the body, to decompress or decongest the right side of the heart and improve hemodynamics and actually improve symptoms as well. The third would be oxygen. There are some patients that have oxygen desaturation, so using supplemental oxygen in patients who have a correctable oxygen desaturation can be helpful, not only from a pulmonary hypertension standpoint, especially if you're in that WHO group 3, due to hypoxia, can actually help the pulmonary hypertension, but also symptoms as well. Fourth would be digoxin. So digoxin is an old cardiovascular medication and is used sometimes in patients with atrial tachyarrhythmias. So this is a medicine that can sometimes be used. In addition to that, there's kind of some evidence as well that it may help improve the right side of the heart contractile-wise. So it is a considered kind of an inotrope, if you will, in a way, digoxin. So there are some centers that use that as a oral medication to improve right ventricular function. And then lastly, the fifth supportive therapy that's used in some cases is iron substitution. So in patients with a documented iron deficiency, which can be easily detected with various labs and that sort of thing, iron supplementation either in the PO form or the IV form can be used in patients with a documented iron deficiency. So those are some of the supportive therapies in addition to some of the pulmonary hypertension specific therapy that can be used.
Well, that's very helpful and particularly can apply to any physician following these patients. But obviously there are some advanced medicine that most people are not very familiar with, that really we require advanced heart failure specialists and pulmonary hypertension specialists that know these medications best and can prescribe and give access to the patient. And Barry, if you could maybe describe for us, these four main groups of medication, how do they work? What are they, and how do we apply them to patient care? Who, for example, is a candidate for IV medication versus oral medication, and so forth?
Nice little small topic there, Alain. Thanks for that. Well, as you said, there are four major categories of therapies other than the calcium channel blockers. And Jason spoke eloquently about the calcium channel blockers in our last podcast for that small subset of patients who are brisk vasoresponders on initial testing. But beyond that, we look to four categories, and I'll give them in no particular order, although probably it's the order that they're commonly used. And the first are the PDE5 inhibitors, what are called phosphodiesterase inhibitors. PDE5 inhibitors are medicines that are very familiar to the public because they are the same medicines that are used for the treatment of erectile dysfunction and have had major ad campaigns going on for the last several years for that usage. So it's always a bit of a surprise to our patients, particularly the women, when we tell them we're going to prescribe them what essentially is Viagra. We use them as the generic drugs now, sildenafil and tadalafil. Those are medications that are pretty easily obtained. They've become relatively cost efficient as they've become generic, and are medicines that work by inhibiting this phosphodiesterase 5, and in doing so, allow you to retain your own nitric oxide. Nitric oxide is a theme we come back to again and again in pulmonary hypertension. Nitric oxide is a very powerful vasodilator of the lungs, drops the pressure, and in pulmonary hypertension patients, it tends to be low. So by blocking phosphodiesterase, we help you keep on your own nitric oxide longer than you might otherwise. So that's one category. The second category are called endothelin receptor antagonists. Endothelin, again, is a chemical that's present in our bodies. In this case, it's a powerful vasoconstrictor, so we don't want it to work. So we block its receptor. That's very similar to the way we treat body high blood pressure with things like angiotensin receptor blockers. It's the same idea, but the endothelin receptor antagonists are less common drugs and really don't have much other use than pulmonary hypertension. We have 3 of those. We have bosentan, macitentan, and ambrisentan that we use. Those medicines are somewhat restricted in their access, and they remain right now name brand drugs, so a bit on the expensive side. We then move into a category of prostacyclin and prostacyclin-like drugs. These are actually the oldest category of drugs that we've had for pulmonary hypertension, other than the supportive therapies Jason mentioned and calcium blockers. Prostacyclin therapy goes back to the first study of epoprostenol many years ago now in the New England Journal, which was the first medication to make a substantial difference in survival in very sick patients with pulmonary hypertension, and was unfortunately only available as a continuous infusion intravenous drug, had to be administered at home through a specialized IV pump, had to be administered on ice. The patients had to learn to mix their own drug. It was a very complicated therapy, and although very effective, had lots of issues with complications and side effects. As we've moved forward in time, we've developed other strategies with those medications. We've developed different versions of the prostacyclin drugs. We now have a prostacyclin analog that's available orally called Orenitram, which is treprostinil is the generic name. That's an oral version of an IV drug that we know is Remodulin, and those are available. And then more recently, we have an IP receptor agonist drug, Selexipag, which is a drug that we now use that's not technically a prostacyclin, but works through that same prostacyclin mechanism. These are very powerful drugs, very effective, however, also complex drugs. They carry a high burden of side effects. And managing these drugs is complex. It takes some experience and some skill, and they too are somewhat restricted in their availability. And finally, there's a 4th category of drug called the soluble guanylate cyclase agonists or stimulators. This one drug in that category is called Riociguat or Adempas. It's a drug that, again, somewhat parallels the PDE5 inhibitors in that the long and short of it is it's trying to increase your own endogenous nitric oxide. So that's the menu, if you will, of medications that we have to choose from when we're looking at a patient with pulmonary hypertension who either is not a brisk vasoresponder or has been on calcium channel blockers and has started to fail that therapy.
So maybe, Jason, you could help us also define how we, in the patients that are mildly symptomatic, maybe WHO class 1, what do you do for these patients? Do you just watch them when you start them on, PO medication? Patients that have more advanced symptoms, WHO class 2 or 3 get short of breath on minimal exertion, versus the patient that is a class 4 or short of breath at rest. Now, how do you approach these patients, these different patient categories?
Yes, that's a great question. For a lot of things in medicine, including cardiology, symptom burden is always a big buzzword for us. So if a patient is symptomatic for any number of reasons, whether it's valve disease or heart disease or pulmonary hypertension, we kind of put up our antenna and realize that there's, work that needs to be done to get patients feeling better. We strive in the heart failure world as well as the pulmonary hypertension world to get patients to a very satisfactory functional class, or in the heart failure world, it's called a New York Heart Class Association functional class, and then in the pulmonary hypertension world, it's called the WHO class. So in the pulmonary hypertension world, we strive to get patients to a functional class of 1, if not 2. So that patients are resuming normal activities as if they didn't have pulmonary hypertension. This can be measured in lots of different ways, like Barry was talking about, whether it's a 6-minute walk or a cardiopulmonary exercise test or even a right heart catheterization, always striving using these techniques, using this prognostic information to get patients to what we call low risk. So generally speaking, it's easy to group patients into 3 risk categories. And by risk, we mean estimated 1-year mortality. So a low risk person would be an estimated 1-year mortality of less than 5%. Intermediate risk would be 5 to 10, and then high risk would be greater than 10. So we have learned in the pulmonary hypertension world over the last several years that striving to get patients to a low risk status, meaning a less than 5% chance of mortality in a year, is really what we aim to do. So we would like to see, those prognostic markers all low risk all the way down. And if they're not, then that means that there's more work for us to do. So usually sequentially adding on therapy is very suggested. The PDE5 inhibitors are kind of the first line treatment for a lot of patients, and then moving on to the ERA or the endothelin receptor antagonist, optimizing that, titrating that. And if patients are still symptomatic or still not low risk, then going on to the prostanoid class of medicines, whether that's oral or IV or sub-Q or inhaled, all the different flavors that we have for that class of medications. What you usually start with can also be very center dependent. We can get into that a little bit later in this podcast about some of the clinical trials and data. But generally speaking, starting medicines and adding medicines in order to achieve a low risk status is really what pulmonary hypertension is all about.
So it appears that the patients that are short of breath at rest, the class 4 New York and WHO class, you would be pretty aggressive with them and start very likely with IV medication, wouldn't you?
Yes, that's correct. So generally speaking, the sicker the patient, the more aggressive you have to be. So in these very sick patients that are, WHO class 4 or advanced class 3, you're going to be looking at IV or sub-Q, some sort of parenteral, so non-oral formulation of a prostanoid, and then very quickly layering on your PDE5 and ERA on top of that. So these patients, if tolerated, and because they're so sick, you usually are in the hospital, these medicines are started with an urgency and up titrated, quickly under the close guidance in an ICU. Sometimes with a monitoring catheter called a Swan-Ganz catheter, which is like a Reinhardt cath, but is continuously providing you information in order to get these patients on therapy to improve their hemodynamics quickly. So yes, the degree of sickness of a patient, so to speak, does dictate the cadence as well as the selection of medications. So all that is obviously very individualized to the patient and can be something that requires a kind of patient-physician discussion and very individualized management situation.
So Barry, it looks like in these patients that are very sick, the sickest, it looks like the trend is really to start these medication on combination therapy right from the start. Isn't that what's happening now?
Yeah, and honestly, Alain, even in the milder, the patients who are class 2, we have now a couple of trials. Probably the most significant trial that's altered practice, I think, in a meaningful way is a trial called Ambition. Ambition was a direct comparison between the use of a PDE5 inhibitor, tadalafil, and ERA, ambrisentan, together or each separately with placebo in patients with at least moderate symptoms, but not necessarily these very sick patients that Jason was talking about who merit intravenous therapy initially. And the results were very positive that combination therapy offered significant benefits over either one alone. So I think that's become, I would say, probably standard of practice in ambulatory outpatients with pulmonary hypertension to fairly quickly, if not simultaneously, move to at least 2-drug therapy early on in their course.
Along those lines, Jason, do you want to tell us a little bit about the Triton clinical trial that was just released at the European Congress of Cardiology?
Yes, so as Barry suggested, the Ambition trial, which was 2015, was a landmark trial showing that combination therapy, so not using just one medicine, but 2 medicines up front, 2 of the classes, was beneficial in patients. So then, of course, the logical question would be, well, what about doing 3 medicines, all 3 medicines up front? So that was the Triton trial, was looking at all 3 classes up front for newly diagnosed pulmonary hypertension patients. So the treatment arm was using a medicine called selexipag or Uptravi, in addition to macitentan and tadalafil, where the control arm was looking at just macitentan and tadalafil. So the main difference between the 2 treatment groups was adding selexipag, which is a prostacyclin receptor agonist. It's an oral formulation, so it's a little bit easier to take and use without having to deal with IVs or subcutaneous pumps. So this medication or this trial, unfortunately, the primary endpoint was not met. The primary endpoint was a combination of endpoints looking at pulmonary vascular resistance, which is a hemodynamic marker that we use on MyHeart caths. Also looking at 6-minute walk test, and then the N-terminal proBNP, which is a kind of a prognostic marker that we use for pulmonary hypertension patients, also kind of a loose measure of fluid status in someone's body. So that combined endpoint, there was no difference between the double oral combination versus the initial triple oral combination. So a little bit disappointing. We would have expected potentially that these results would have been positive. However, there was a sign of reduced risk of disease progression on the initial triple oral therapy. So some of the secondary endpoints were positive. And showing that reduction of risk progression is an important, outcome, although it wasn't the primary outcome. So I think that there's going to be probably further studies, further trials looking at these, at upfront triple therapy. Of course, this was just using one prostanoid. We have a whole family of different ones. So maybe a different, more potent prostanoid up front might be helpful. So again, technically a negative trial, still had some interesting results. And I think that the idea of upfront triple therapy is still a good idea. And it probably still requires more and will have more further investigations in the future.
I think Triton, I'd be interested in Jason's take on this. I think Triton was an ambitious trial in its design. And I think one of the places it might have been a bit overambitious was the speed with which they expected. It was a fairly short trial to achieve a combination endpoint that they had structured. And certainly if positive would have been a home run. But I think it was they set themselves a very difficult hurdle.
So their objective was 30 months, wasn't it? They looked at the data after 2.5 years?
Yeah, it was about 80 weeks, yeah.
Yeah. Well, yeah. I think it's pretty encouraging to see that, they still had some, reduction in hospitalization for deterioration of pulmonary hypertension, as well as, improvement, in the time to all-cause death. There was some very positive, results, but overall, did not achieve its goal. But there was some very interesting findings, I think, in that trial.
I agree, and then of course we always, tolerability and safety. So both of those checked out okay. There weren't any increased side effects or adverse effects with the upfront triple therapy. So I think it's always hard in the PH world because these numbers are small. There is not a whole lot of randomized controlled trials. A lot of times, at least in my opinion, I don't know what Barry thinks, especially coming from the heart failure world, where in heart failure we have very hard outcomes. We're talking about mortality, hospitalizations, these sorts of things. In the PH world, you have kind of some loose outcomes, like 6-minute walk test and usually some biomarkers, that sort of thing. So it's quite not as hard endpoints as other areas of medicine. So having a short trial with kind of the soft but accepted outcomes or endpoints may have contributed to maybe it not being as strong or positive as a trial as it could have been.
Yeah, I agree with Jason. We as people, both Jason and I work in the world of heart failure and the world of pulmonary hypertension, and you have to lane shift a little bit from trials with thousands, if not 10,000 participants with very easy to measure hard endpoints, as Jason said, to a trial like Triton, which we consider honestly a monumentally important trial in its conduct, and it enrolled, I think, 247 patients over a fairly long period of time to get that number. So it really is a real difference just because of the rareness of this disease to gather useful information in a meaningful way.
Barry, let's talk about the cost a little bit of these medications. In the heart failure world, it's already a difficult subject, particularly, treating a patient with medication like SGLT2 inhibitors that cost, $500 a month. You have the Entresto, which is over that even per month. It's not difficult. It's pretty difficult to implement best therapies, for our patient. In the pulmonary hypertension world, it's obviously even more of a problem. What are the costs and how do you do that?
Yeah, it's always been a difficult situation. I will say it's gotten progressively better. We now have the PDE5 inhibitors are generic. We have some of the endothelin receptor antagonists generic. That's not to say that they're inexpensive, but they have started to move more in that direction. Prostacyclins and some of the ERAs and the soluble guanylate cyclase inhibitors are still very expensive drugs. I will say that our industry partners, as well as some other organizations that are out there, have been very, very good at stepping up for our patients. And I have to say it's fairly rare that I cannot get coverage for a patient for therapy that they need. It may take some shenanigans. It may take some work. I am blessed with, Anna is my nurse coordinator. Anna is literally a master of the game. And I give the order to Anna, then a miracle occurs, and out the other side comes a patient successfully treated and somehow at an acceptable price. So she has really mastered this. And largely that is due to the, I think, generosity of the corporate partners and other charities that are available to help our patients. So we can usually get it covered.
Jason, do you have also a miracle worker?
Yes, we all have our own miracle workers. The only real way to have a pulmonary hypertension program work is to have a pulmonary hypertension coordinator. And even though this is a rare disease and a lot of times you don't have a lot of patients, this is still a full-time job. These patients are very complicated. They have lots of questions. I don't want to use the term needy in a negative way, but they just have a lot of things that they need. In addition to that, the medication authorizations, working with the companies, working with any sort of patient assistance, and of course the insurance companies requires a lot of work, a lot of faxing. Yes, we still fax. This is 2020 and the fax is still alive and well in the pulmonary hypertension world, which is shocking to me. And then all the things that go along with that: lost paperwork, lost faxes. We didn't get this, we didn't get that. The patient didn't sign it on this day. It really is a multitude of hurdles to get patients, treated and on these medicines. And then it all repeats again at the beginning of the year when they get new insurance or everything cycles all over again. So it's a never-ending battle. Just when you get them accepted and on medicines, then in just a few short months, you're going to have to do it all over again. So yes, we all have a special person that is kind of the point person for this, and they definitely are incredibly important and worth their weight in gold.
Important to have this, the heart team approach, with the coordinating centers and trying to get all the resources together for these patients. An incredible contribution to the treatment of this very difficult disease. Where do we go from here? What kind of research is being pursued, for example, at your center, Jason?
Yeah, there's a lot of exciting things going on in pulmonary hypertension. You have on the device side, fully implantable pumps, which are now on the horizon, currently being used in select centers, but should be available nationwide, hopefully first quarter of next year. So patients who were on, sub-Q, which requires an external pump, or IV, which requires obviously an external pump, can now be housed internally. So it's like a pacemaker. Everyone kind of knows what a pacemaker is, and that pacemaker pocket has a refillable bladder that then pumps the medication. So everything is internal. So being able to shower or take a bath or go to the beach or be fully submerged will now be an option for some of these patients where it wasn't before. So that's obviously a huge advancement. There's also improvements on the inhaled form of some of these medicines. The current inhaled form is a medicine called Tyvaso, which is treprostinil. It's done 4 times a day. Trying to make that, and it's a huge kind of unit that patients have to use, trying to make that smaller with a dry powder to make it a little bit easier for patients to take is another kind of advancement in that world. There's also new medications and new technologies as well. So one of the kind of newer medications that's being tested is medicine called apelin antagonists, which is kind of a new kind of breakthrough medicine that's recently trialed in kind of a small trial that showed kind of beneficial hemodynamic effects. So maybe a new IV medicine sometime in the future. And of course, probably the biggest one that's had a big splash is pulmonary artery denervation. So actually going in and extinguishing some of the nerves that innervate the pulmonary artery system to actually relax these vessels to kind of counteract some of the hormones and signaling molecules that actually constrict the pulmonary arteries. So this will be in addition to medications, and the initial investigations have been very positive. So patients that have been either resistant to medicines or have failed medicines, and even people that have been on medicines, there's an incremental benefit potentially with pulmonary artery denervation. So lots of exciting things in the field of pulmonary hypertension, like a lot of fields, ever advancing, and hopefully going to be better for our patients, even better for our patients in the near future.
Is this the same type of denervation that we've seen for the treatment of hypertension with the renal artery denervation? This catheter technique and different.
That's correct. Yeah. Yeah. Using ultrasound. Yeah. Using ultrasound to denervate the pulmonary arteries. Yep. Barry?
Yeah, I think that's right. I think Jason's right. It's an exciting field because it's a field of ongoing evolution. I'm old enough to date back to the original epoprostenol trial when we emerged from the era of literally having nothing other than calcium channel blockers for those select few, and have seen all of these therapies evolve in the course of my career. And it's fun to see it continue to evolve to be able to provide our patients with other things. Just to add to the things that Jason mentioned, I just saw an interesting abstract about right atrial pacing, improving hemodynamics of the right ventricle in patients with pulmonary hypertension type 1. So there are a lot of ideas, a lot of strategies out there that I think are intriguing. There are a couple of other therapies we haven't touched on that are of limited utility because of the complexity. Things such as atrial septostomy and ultimately lung transplantation, which certainly serves a role for a small number of our patients, but for those few, maybe a life-saving and very important therapy as well.
Well, it seems like the future is getting brighter for these patients with a very difficult disease, pulmonary hypertension. I think we're going to see further development of these treatment within the next few years, something to hope for if you're a patient with pulmonary arterial hypertension. Well, gentlemen, I want to thank you very much. This is a great information about the treatment of these patients with pulmonary hypertension when vasodilator medicine don't work. Barry, thank you very much. And Jason, we'll talk to you next time. Appreciate your help.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.